So good evening, one and all present here. I am Suchira from Science Integra, and I welcome you all for this 6th webinar of Maha Smiles Cleft Care for Every Child. I would like to introduce you all to Dr. Charvi, who is the Program Officer of Smile Train India. Over to you, Dr. Charvi.
Thank you, Suchira. Good evening, everyone. I'm Dr. Charvi, Program Officer from Smile Train India. I would briefly tell you about Smile Train and our initiative called Maha Smiles in Maharashtra. So to tell you about Smile Train is the world's largest cleft-focused NGO that supports 100% safe and quality cleft care for children globally, enabling them with the opportunity to live full and healthy lives. Over the past 24 years, we have partnered with more than 150 hospitals in India and have supported more than 7 lakh surgeries. This initiative of Smile Train with Bajaj FinServ is a CSR collaboration. We call it Maha Smiles with Bajaj FinServ. We aim to build awareness and support treatment for children with clefts in Maharashtra. Maha Smiles will enable nearly 8,000 life-transforming cleft surgeries. The aim is to help children with clefts live and help them live healthy lives. We have 11 free treatment centers in Maharashtra across 10 cities. And we have our helpline number here. This is a toll-free number, 1800-103-8301. You can reach us at this number, or you can also reach us at www.smiletrainindia.org. Thank you. So now I would like to introduce Dr. Sujit, who is also our moderator for the webinar today. Dr. Sujit, can I have his CV, please? So Dr. Sujit is a certified FMF certified for 11 to 13 week scan, PE screening, Doppler ultrasound and fetal abnormalities. He is the chairperson of Fetal Medicine Committee, AMOGS, and he has done basic UCG training at Dr. Bimal Sahni's Sonoscan Center in Aurangabad. He has been moderating all our webinars. This is the 6th webinar in the series, and I have to thank him for this wonderful job that he does. Nobody can do it better than him. By far, we have loved all his sessions. So over to you, Dr. Sujit.
Thank you for nice introduction, Charvi. Good evening, respected seniors, friends, and colleagues. Here we are going to represent the 6th ECME of cleft lip and cleft palate. This series has been started jointly by AMOGS and Smile Train to spread awareness about cleft lip and cleft palate amongst our society, among all our doctors, obstetricians. We are very much thankful to our President, Dr. Rajendra Singh Pardeshi, sir, our Secretary, Dr. Sujata Dave ma'am, President-elect Dr. Kiran Kurtukuti, sir, and entire office bearers of AMOGS who is giving constant support for these activities. I would like to welcome our convener today, Dr. Jaya Tulaskar. Today we are having two esteemed speakers, guests. First one is Dr. Ashwini Kale. She is going to talk on overview of the cleft lip and cleft palate, and Dr. Nitin Mukkal sir, who is going to talk on management of cleft lip and cleft palate, with more emphasis on secondary surgeries. Welcome, respected speakers. Now I invite and welcome Dr. Jaya Tulaskar for the further proceeding. She is MBBS MS OBGYN and she has also done postgraduate PG diploma in maternal child health care. She is also having diploma in reproductive medicine and infertility from Germany. She is
Suda.
खूप मोठा एकदम लागतो मला.
नाही सर, नाही लागतो, please. Thank you.
Okay. Over to you, Dr. Jaya, for further proceedings.
Yes, sir. Again, good evening, everyone. Not all smiles are created equal. So efforts by this Smile Train India and Bajaj FinServ for shaping smiles through this awareness campaign is really admirable. So let's start our first session. Can I have CV of Ashwini ma'am? Our first session is cleft lip and cleft palate, an overview. So our esteemed speaker for this talk is Dr. Ashwini Kale ma'am. It's my great honor to introduce her. She is Chief Embryologist at Asha Kiran Hospital and Asha IVF Center, Pune, Arunachal Pradesh, and Hyderabad. She was secretary of Pune OBGY in 2021. Now she is chairperson of AMOX YTP committee. She was elected MCM at ISAR, MCM Maharashtra chapter ISAR in 21-23, zonal coordinator of AMOX 18-20. She is peer reviewer of Yogi from 2016 till date and has been awarded Foxy Sun IAAC Traveling Fellowship in 21 and Foxy Shanti Yada Award 2022. I welcome you, ma'am, and invite for your talk.
Yeah, thank you so much, madam, for the kind introduction. I'll just share my screen. Is it visible?
No, ma'am.
Not
Not
yet.
Yeah. First of all, I thank all the AMOG's office bearers, Dr. Pardeshi sir, Mane sir, Sujata Darvi madam, and President-elect Dr. Kiran sir for having these webinars, and Dr. Sujit and Dr. Rashmi for conducting it so religiously for, I think, over 6 weeks now. So I think, is my screen visible now?
Yeah, yes.
I'll just
Yeah, it is
put
visible
one
now.
slide.
Yes.
Yeah,
Please make it full screen now.
yeah, I'll do that. Once. Sorry. Oh, why it's not happening? It's not happening on slide share. I'll just try in between my talk. It's not happening. I'll just try and share again. Sorry.
Yeah.
Yeah, yes. So thank you so much for giving this topic to me, cleft lip and palate. I must say this is very close to my heart because my father was a plastic surgeon and I've seen him operating these children for many, many years, and I could actually see the distress the parents had with a child born with a cleft lip and a palate also, because even the everyday food intake or even the water intake used to be so difficult for these kids. And I had seen him working so closely in so many camps. And initially I used to feel, why is he working so much for these children? Why do such camps and all when you can get paid heavily? But today when he's not there, I truly understand how much he's worked for this. And today talking on the same topic is, I must really thank you, Sujit sir, for inviting me. If it wasn't for you, I would have never ever got an opportunity to talk on this. So basically, this is the most common congenital anomaly which occurs at the orofacial region. It can occur either in isolation or in combination. And treating this at the right age and the right time is very important. A multidisciplinary and an interdisciplinary with a coordinated care action is required, which is very important because the parents have to be counseled saying that this is a treatable condition. So cleft lip is nothing but the failure of the fusion of your frontonasal and maxillary processes. This results in a cleft lip, which is either through the lip, alveolar, or the nasal floor. And a cleft palate is nothing but a failure of fusion of palatal shelves of maxillary processes. This results in a cleft either in the hard or the soft palate. And during the 4th stage of development, appears when location of failure of fusion occurs in the embryonic life when there is interference with the development. The frontonasal prominence develops into the medial and the lateral nasal prominences, and the two maxillary prominences grow towards the nasal prominence, and it creates the nasolabial region and the lip. This fusion, if this fails at around 5 weeks of the embryonic life, it leads to the formation of cleft lip. Going back to embryology days, remembering the morphology of the face, we know that there are 5 fundamental facial prominences. The primordial mouth develops at 4th week of gestation with the frontonasal prominence. There are 2 bilateral maxillary and 2 bilateral mandibular prominences. The frontonasal prominence develops into the medial and lateral prominences, whereas the 2 maxillary prominences, they go towards the nasal prominence and it creates the nasolabial region. At the same time, the development of the palate also begins, and it is completed around 12 weeks. This median nasal prominence fuse in the midline and it forms the primary palate. The medial side of the maxillary processes rotate and it develops into the lateral palatine processes and fuses in the midline to form the secondary palate. This failure of midline fusion leads to the cleft palate. So it is very good that because of this developing ultrasound that we can diagnose this at 12 to 14 weeks. So this is how a complete cleft lip palate looks on after birth. This is obviously before the repair. And the cleft of the soft palate only. The equal sign, which is a novel marker in the diagnosis of fetal isolated cleft palate, which is a marker on ultrasound. So this is how the equal signs looks as, and you can detect this very early in life so that the counseling with the parents becomes very easy. So this is how all the cleft lip and palate looks like. Incidence, the isolated cleft lip is only about 15%, whereas the cleft lip with the palate is 45%, which is the most common abnormality which is found. And an isolated palate that is either on one side is around 40%. The causative agents could either be syndromic type, it could be a single gene mutation, or it can even be non-syndromic type or an unidentified cause. The non-genetic causes are smoking, alcohol, stress, or chemical exposure, or even advanced age of the mother, diabetes, or drugs like valproic acid, phenytoin, retinoic acid exposure. The clinical features which are seen in the baby are there are feeding problems with the neonate, failure to thrive, there is a lot of speech problems, hearing problems, and even dental problems. Management is education, counseling the patients, and treating them at the right age and the right time. And psychosocial rehabilitation is very important because I've seen these patients, even after the treatment, they have to work a lot on their speech. It is not very easy to work on the speech because in those developmental years, using your tongue, cleft, and the palate for the speech is very important. So it is finally a multidisciplinary approach, which Dr. Nitin sir is going to take in his next talk, where we will come across how this is actually treated. So I must really thank you once again, sir and Amox, for this opportunity, and looking forward to hearing Nitin sir for all the treatment options. Thank you once again.
Thank you so much, ma'am, for this elaborative and wonderful session. So, moving on to the another session. Nothing is more beautiful than the smile that has struggled through the tears. So, the next talk is management of cleft lip and palate, more emphasis on the secondary surgeries. The esteemed speaker for this talk is Dr. Nitin Mokal, sir. It's my honor to introduce you, sir. Sir is director at Smile Trade at Susrusha Citizen Cooperative Hospital and NH Children's Hospital, Haji Ali. He has done plastic surgery training from Lokmanya Tilak Medical College, Sion, Mumbai, cleft and craniofacial fellowship from National University Hospital, Singapore, and Changung Memorial Hospital, Taiwan. Sir is past president of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies. He is past president of Association of Plastic Surgeons of India, executive trustee of Indian Society of Cleft Lip, Palate and Craniofacial Anomalies, and there are 25 publications and 3 book chapters to his credit. I welcome you, sir, and invite you for your talk.
Thank you very much, Dr. Jaya, for the kind information and introduction. It gives me great pleasure to be part of this particular webinar, which is associated with your association and a Smile Train. I have been instrumental in Smile Train since last 24 years. When the Smile Train got introduced to India, I was the 3rd plastic surgeon working on these cleft lip palate patients at Wadia Children's Hospital. I worked there with this particular partnership for almost 6 years, and then we shifted to Susrusha Hospital, and then Smile Train bestowed me the responsibility to partner with another hospital, that is SRCCNA Children's Hospital. So at present, I am running two Smile Train partner hospitals, the Shushusha and SRCC Children's Hospital. And it is very important that a primary surgery done gives a better chance of developing less secondary deformities. So it is very important to send a patient to a proper uh, care center where these type of surgeries are done and regular intervals. There are also certain good medical plastic surgery units in a teaching hospital. They do also do this type of surgery with equal expertise. With that, I'm going to present on the secondary deformities of the cleft lip and palate, and uh, I'm going to overview about these surgeries in a nutshell. So what we want to achieve in smile in a patient with the cleft lip and palate is achieve the symmetry, of the both the nose, alar base, achieve the symmetry of the lip, continuity of the lip in the terms of a white roll, in terms of a white roll, in terms of the vermilion where there is a dry and wet vermilion. You can see that this is a line which is joining the dry and wet vermilion. And the function in terms of a feeding, function in terms of the speech and dentition. So I have divided the cleft deformities into three parts. The extraoral soft tissue deformities like scars, contractures, and lip nose asymmetry. Intraoral soft tissue deformities like the soft palate breakdowns and velopharyngeal incompetence. Orofacial skeletal deformities like anterior palatal fissulas, dentoalveolar, and maxillomandibular jaw occlusions deformity. So in the unilateral lip and nose deformities, what you have come across is a scar, white roll mismatch, raised cupid's bow, vermilion dry and wet mucosa mismatch, hypoplastic cleft lip segment, alar columnar tip, and dorsal nasal deformities. So if you see this particular young patient, he reasonably well done lip, considering he has been operated 18 years back. But you can see that these are the people who they want a little more improvement. And you find that this patient has got a cupid's bow which is up. It is called, we call it as a peaking of the cupid's bow. They will find that the dry and wet mucosa is mismatched here. And there is classic whistle tip deformity, which we call it as, and a scar which is extending onto the alar base area. So these are the patients, they require a revision, and the final revision will improve the appearance of this young child. So what we do is that we excise the scar, mark the landmarks. We bring this cupid's bow down by creating a Z here. We make a Z plasty of the wet mucosa and the dry mucosa, and we realign this into a normal position. We give the continuity of the white roll. Then we make a small Z plasty of the scar, so that when you break the scar, it heals well, and it also releases that peaking of this cupid's bow on the cupid's bow, so it brings that cupid's bow to normal level. And if you see that on closure, you'll find that this wet mucosa is very well restored, and the dry mucosa is well restored, and the alar symmetry is restored. And this is how is on table. You can see that the restoration of the scar and continue, and this is the long-term result, where you can see that whistle deformity is gone, the dry and wet mucosa is very well aligned, and the continuity of this white roll which is very well maintained. Another similar type of patient where the scar has been revised, and what we do is that if the patient has got a hypoplastic element in this, then we also use the aesthetic surgical principles, where we harvest a small amount of a fat graft from the tummy, and we inject the fat into the upper lip to provide this bulkiness for the lip and to provide that fullness into the lip. So this is the lateral and profile. Then some of the patients after repair, they do have a scarcity of the hairs along the suture line. You can see that these are the hairs which are less in this area. So I refer these patients to my colleagues who are expert in doing a hair transplant. So they harvest the hair from the beard area and then they transplant into the area of the scar, and you can see that the entire scar gets camouflaged well with the help of a hair transplant. This is another patient done by my friend Sandeep. Then comes 100% all the patients, they come across this type of deformity. No matter you do whatever nose correction primarily, most of the kids, they do have this type of a nasal deformity called as a classic alar deformity, where there is a downward displacement of the alar cartilage, decrease in the columellar height on one side. You can see the height of the columella is decreased, the alar cartilage is downward displaced, and even this alar base is wide. You have to treat these patients. And if you see anterior posteriorly, it not only shows that alar deformity, it also has got the septal deformity. The septum is curved anteroposteriorly as well as vertically. Sometimes there is a dislocation of the septum from the nasal spine. So these are the patients, they do have functional problem like obstruction, breathing difficulty, as well as the aesthetically the nose looks bad. So we do open rhinoplasty approach. By open rhinoplasty approach, we expose the alar cartilages. You can see that this is the affected alar cartilage which is downward displaced. We bring that alar cartilage to its normal position by releasing this cartilage from the lateral element and bring that cartilage to its new position, leaving behind this defect here, which will be reconstructed over the period. And you can see that the alar cartilage is restored to its new position. At the same time, we harvest a septal cartilage graft. We take a piece of the septal cartilage graft, and this what it helps us in restoring the septal cartilage stability and the correction of the deviation. And this graft, we use it as a columellar strut. So this supports both the alar cartilages, also it supports the existing septum. It provides a good midline support to the airway, as well as provides support to the alar cartilages. And you can see that because of this, you get a good stable midline cartilages, and we restore it to a new position. And there is a defect in the cartilage here in this area. So we put in another cartilage graft here called as the alar extension graft. You can see that this is a midline graft and this is a alar extension graft, which provides a symmetrical support for your nose to stabilize in a pyramid fashion. Then there is a widen alar base where we can narrow it by Y to V advancement and narrow to its opposite side. This is how we narrow the alar base, and then after narrowing, there is excess amount of this skin, overhang of the skin, which we raise it like a flap, and we put this extra skin inside the nostril to prevent the contracture because there's a raw area there. So this is how you attain alar symmetry and the nasal projection on table. You can see that it is achieved, and this is pre-op and the post-op on table result, where you can achieve the symmetry, restoration of the alar cartilages to its new position, as well as the revision of the upper lip. And this is how you can see the alar symmetry being achieved on table. Sometimes we do this nose correction at the time of alveolar bone grafting. Most of these patients do have a alveolar gap, and one of the operation is conducted is called as alveolar bone grafting, which is in the mixed dentition. Our orthodontic colleague aligns the arch nicely, and which creates a fistula here in the dentoalveolar fistula, which need to be covered because your canine or lateral incisor comes into this area. So we do a surgery called alveolar bone grafting. This surgery is also supported by a smile train, which is one of the very important surgery in a growing child. And these are the patients where we identified the bony gap. We corrected the bony septum here, harvested the bone cartilage graft from here, and then we have restored the cartilage graft. And this bony defect, we have repaired the nasal lining, we have repaired the oral lining, and this three-dimensional defect, we filled it with the help of a cancellous bone graft harvested from the iliac crest. We take a small incision, make a hole into the iliac crest, and with the help of a gouge or a special trephine, we remove this cancellous bone graft, we pack this area with the cancellous bone graft, and then we close the wound. And you can see that this is the time where a child is going from puberty to adulthood, so childhood to adulthood, and there is lot of psychological impact. So what I do is I do alveolar bone grafting, at the same time I correct this nasal correction. So the patient has got the no psychological depression and no impact to go into the society. And you can see that his arch is very well aligned, and you can see his scar is revised, his bony symmetry, nasal symmetry is being provided, and this is the pre-op and the post-op result showing the symmetry. So it is very, very important to do this surgery at the time of alveolar bone grafting, a small touch-up at the time of alveolar bone grafting, which will provide a good appearance to this type of patients, pre-op and a post-op. And this particular article I have published in Indian Journal of Plastic Surgery. It's a composite correction of unilateral cleft lip nose deformity and alveolar bone grafting simultaneously, along with my orthodontic colleague Dr. Chintamani Kale and myself published this particular article. These are the results in adult patient nose deformity corrections, the pre-op and the post-op, the lateral view. Try to achieve as much symmetry as possible with no scars. Then comes the bilateral cleft lip deformities. In bilateral cleft lip, there are scars. There is midline vermilion deficiency. The columella is short and shortage of the upper lip. So I have divided these deformities into three types, where it is a surgical classification where you see that you have adequate soft tissue in the upper lip, you have got adequate skeletal framework, so you don't have to import any tissue or import any cartilage from outside. Then second part is you have got adequate upper lip soft tissue but inadequate skeletal framework, nasal skeletal framework. So you have to import some amount of skeletal framework for the nasal correction. And then type 3 is inadequate upper lip soft tissue and inadequate nasal framework, where you have to incorporate and import both soft tissue to the upper lip as well as the nasal skeleton to the upper lip, to the nose. So this is a patient where you can see that it is luckily the person has done a reasonably good job without disturbing any soft tissue. So if I am doing a secondary work, I have got good quality of upper lip. You can see that here she has got a good adequate upper lip soft tissue. She has got a good white roll which I can use it. She has got a good filtral column skin area which I can reuse it for the reconstruction. So the first and foremost is the columella, which is shorter. So what we do is that we take a skin flaps from the existing prolabium, which is wide, and this is the aesthetic unit for the filtral column. So we raise these flaps together. We raise these two flaps and we use these two flaps for lengthening the columella. Then we realign the new white roll and new pupils bow, and then we restore back this subcutaneously based central prolabial segment to its new position to create this columella and the lip revision at the same time. So this is how you lengthen the columella, created the vermilion and created the new filtral column. And this is the result. You can see that this is a pre-op where there is no columella. So we created the columella, we restored the upper lip continuity and restored the good cosmetic unit in the midline. You can see the profile. In this profile, you can see that the good columella lip angle is provided. You can see that the lip pout is provided well. So the facial symmetry got restored very nicely. And she got married immediately after the lip and nose revision. Another baby with the columella lengthening and adequate upper lip. So this is the girl where pre-op and the post-op. You can see the restoration of the upper lip, restoration of the muscle continuity, and restoration of the cosmetic unit and the nose. This is another adult patient. So this is another article which I published in Indian Journal of Plastic Surgery, a novel technique using subcutaneously pedicled island prolabral flap for secondary correction of bilateral cleft lip and nasal deformity in Indian Journal of Plastic Surgery. This is type 2 where there is a upper lip which is adequate, but the nose is very depressed. You can see that there is no nasal support to the lower half of the nose. So what he requires is a lip correction as well as some sort of a nasal correction. So we harvest the costal cartilage graft. We use one piece for the nasal dorsal augmentation, one piece for the columella, two another pieces for its alar extension graft. And this is on table. You can see that his lip has been provided, the nose has been correctly lifted up, and then you can see a 3 months post-op where the lip continuity is very well maintained, the restoration of the both alars, the tip, and in profile you can see that a good profile is maintained, good lateral columella angle is maintained. And now this child, he's done his masters in Cleveland State University. He sent me this particular photograph. See, the amount of confidence you can provide in this type of patients is phenomenal. And this patient, it is type 3 where there is upper lip shortage. You can see there is upper lip shortage. The nose is absolutely stuck to the lip and it requires both skeletal and soft tissue restoration. So here what we do is that we use the upper lip skin for the columella. We use the costal cartilage graft for its dorsum and the columella support, and then we bring back this columella back, and this there will be a you can restore the nose with this support, and this columella is reconstructed by the prolabial skin. And now this soft tissue defect can be used by using the lower lip, because lower lip is always larger in bilaterals. So you can take a flap called as an Abbey flap based on this artery here, labial artery, and then we stuck this flap up. So this is that Abbey flap which is harvested and which is stuck to the defect to reconstruct the new filtral column and new central vermilion. And the donor defect is again sutured by a Z plastic to prevent a scar contraction. So this is after doing that Abbey flap, and then we can divide this Abbey flap after 15 days. Once the establishment of the blood supply to the upper lip, and you can see that the result after division after 3 months, you can see that a good upper lip continuity, the good nose correction, good columella, good nose. You can see the profile. The upper lip is good provided, the lower lip and the profile here. Another patient with similar technique, nose rhinoplasty and Abbey flap. You can see the profile. This is the patient where we did the jaw surgery, and then after jaw surgery we did the Abbey and the rhinoplasty. Another patient with a similar technique, Abbey and rhinoplasty. So this is another article where secondary bilateral cleft lip nose deformity correction by rhinoplasty and simultaneous Abbey flap. This is again published in Indian Journal of Plastic Surgery. Then we go intraorally. Intraorally, there is always a fistulas, there is always a breakdown. If it is not done properly, you can see that this particular patient has got the posterior breakdown. This particular patient repaired by a pediatric surgeon in a native area, and this can be repaired by using a buccal flaps. We take a cheek flap from the side and we restore this continuity with the help of a buccal flap. Another patient with the soft palate breakdown repaired with the help of a bilateral buccal flap, where you want to restore the continuity as well as restore the velopharyngeal competence. Then there is an anterior fistula. You can see that a huge anterior fistula. So in order to do that, we require a 2-layer closure. We turn down the local flap to close the nasal lining. You can see that the nasal lining has been closed. And this particular area, we use a tongue flap. Use a part of the tongue. It is a anteriorly based dorsal tongue flap, which contains the mucosa and the muscle. based on the anterior blood vessels of the tongue, and then we suture that tongue flap into the defect, and we divide this tongue flap after 3 weeks. You can see that the fistula is covered nicely after division of the tongue flap. The most commonest complication of palate surgery is because we raise the mucoperiosteum, there is always a scars inside, and the scars they pull inside. There is detrimental growth on the growth is hampered of the maxilla, thereby causing this classic class 3 malocclusion deformity. If you see on a lateral view, the maxilla is way behind. Because maxilla is way behind, there is no restriction to the lower jaw, so lower jaw grows disproportionately. So this particular deficit is almost 13 to 14 millimeter. So in order to bring this forward, we have a new technique called as a distraction osteogenesis, where we do the osteotomy and we bring the jaw forward on an incremental basis. We bring the jaw forward on an incremental basis. So what it does, it creates a new bone based on that Elizarov principle, where it creates a new bone behind the maxilla, and gradually the maxilla is brought forward after using this distraction. And you can see that on a lateral films, you can see that we start the distraction on 5th post-op day and gradually go on rotating the screw onto this distraction frame and bring the jaw forward till it crosses the lower jaw. So this is how is the result, and you can see this is after the jaw distraction and this is after the rhinoplasty, and this is a profile. So one should be in position to give this result by both doing the foundation first and then the rhinoplasty later on. Another patient with the similar type mass malocclusion, dental alignment is in poor hygiene. These are the patients I refer to my dental colleague. He is orthodontist and he realigns these arches. You can see that both the arches are realigned well. And now this patient is now ready for its orthognathic surgery, where you want to bring the jaw forward and the lower jaw backward, called as a BSSO and Laporte 1 advancement. So this is the occlusion, which is almost 11 millimeter occlusion deformity. So we do take a CT scans and we plan our surgery, and this is the planning where it says that you bring the jaw forward by 5 millimeter, you bring the lower jaw backward by 7 millimeter, and you reduce the chin by 4 millimeter to give that proper profile to this patient. So we take the dental models and transfer the dental models and do a mock surgery, and the orthodontist give me these two splints called as the intermediate splint and final splint. The intermediate splint is after the jaw osteotomy, the maxillary advancement, then a second splint after the BSSO jaw reduction. So this is how we go intraorally and reduce, do the osteotomy, fix the maxilla with the help of L plates, then do the mandibular osteotomy, setback osteotomy. You can see that this is a 7 millimeter reduction in the jaw, and then we do the cutting of the lower jaw and fix it with the help of a plate and a screw after reduction. All these surgeries are done intraorally without any scars outside. Then a genioplasty, where we do a cut on the chin and bring the jaw backward by 4 millimeter. You can see that it is done brought backward by 4 millimeter. So we did 3 surgeries: the Laforte advancement, the BSSO setback, and a genioplasty reduction genioplasty. And whatever bone piece which was removed, 7 millimeter bone removed from both BSSO, we have placed it in the area of the alar base by the plate and screws. And then we fix it there, and you can see the profile on table, and this is the profile immediate post-op, pre-op, and the post-op, and this is the occlusion pre-op and the post-op. This is another patient, a long-term result. Another patient, a profile is restored with orthognathic surgery. So what is the take-home message? It is very important to assess all these deformities, both skeletal deformities, soft tissue deformities. Involve your orthodontic colleague in planning. Use advanced technologies like CT scan, dental scans for planning your surgeries. Use good quality plate screws use a piezo saw or saw system which is less harmful to the bone to provide the best result, and sometimes soft tissue correction by using advanced aesthetic surgery procedures like fat graft and hair transplant will be beneficial for providing a better aesthetic and functional results in this type of patients. Thank you very much for inviting me for this event. Thank you.
It was excellent talk, sir, with beautiful after surgery pictures after correction, cosmetic corrections. I have one question, sir.
Yes.
If some patient has operated in childhood under
Yes.
Smile Train,
Yes.
again for secondary surgeries also, he
Yes.
he will be covered, or
Yes. They are covered for fistulas. They are covered for soft palate broke down. All these patients are operated. They are covered for rhinoplasties.
okay.
About the orthognathic, they have a designated orthognathic centers. They cover orthognathic also. They cover the orthodontics also. There are designated orthodontic centers where they support this, where the orthodontic colleague who can prepare the patient for the alveolar bone grafting, they are covered with that. So the designated centers are there. They are called tertiary centers. So, but 5 major surgeries: the lip repair,
Okay.
palate repair, the alveolar bone grafting, and nose rhinoplasty. And if there is a breakdown, these are all main important surgeries are covered under Smile Train. And very important is to refer these patients to a center where these are the cases done on a regular basis, like all Smile Train centers, like all plastic surgery units, where units where you can send these patients. One more, just a request that we plan everything. We plan our marriages, we plan our marriage ceremony, we plan our engagements, we plan everything. But this younger generation don't plan the pregnancy. You have to have a concept of planning of the pregnancy. The 3 months,
Yes.
the expectant mothers, these kids, they should plan themselves. They plan themselves a healthy lifestyle, provide them with a good B complex zinc deficiency tablets, provide them a healthy lifestyle, give them a good advice. I think that initiation your association can take, because I have been telling lot of these reporters, they want all these stories with all masala. They are not interested in this. If you see all young girls, they are all smoking, drinking, and other things. How do you expect this younger generation to produce a normal child? I think your association to take up this matter and convey that you have to plan your pregnancy and start this planning for 3 to 6 months in advance with
Yes.
healthy lifestyle. Then only we can reduce the at least incidence of these congenital deformities.
Yes.
Yes, that is very good suggestion, sir. Actually, preconception folic acid is one of the part of that program, but another screening.
But it has to be given at right time, not after
Yeah,
the conception.
yeah. The screening, preconception screening, also one thing that is come up nowadays to diagnose or screen some genetic diseases. Your talk was very excellent and informative, sir, because most of the medical practitioners are used to see the primary surgeries. That is near normal. They do the near normal anatomy, but the pictures which you have shown in your slides, they are of secondary surgeries we have seen for the first time. At least I have seen for the first time, and which restores almost 100% anatomy and all
Yes.
physiology
Yes.
functional work. So these pictures or slides should be kept in obstetric OPD or OPD of our sonography rooms to explain such patients, because even today there are some patients who demand for termination of pregnancy for diagnosis of unilateral cleft lip also. So this is very pathetic. The job of our sonologist and obstetrician is huge in some areas of our country, or in Maharashtra also. So if such slides are applied on put in your OPD or sonography room, it is very easy to convince them the results of these types of surgeries.
Yes. Yes.
And one more thing, many of the diagrams were of your own, sir. You are
Yes,
very
yes,
much.
yes. I think this is the training given to me by my teacher, Dr. Ravin Thatte.
Oh, excellent
Where
images, sir. Excellent diagrams were there.
when we used to prepare for our conference presentations. So our presentation again used to start 3 months well in advance. We used to have a slides at that time. We used to have that projectors, projectors. So we used to prepare the slides, and my teacher used to, when we present, and the presentation also within that time, 8 minutes paper means 8 minute papers, it has to get over in 8 minutes. Then he used to suggest that Nitin, you put a one line diagram there, which is better for better understanding.
Yeah,
So
that
that is a
gives
habit
good.
now that I usually do my own drawings and put it in my presentation.
That gives good mental
Yes.
printing. Yes.
Yeah. Sujit, I would like to come, when I come to Aurangabad, I'd like to meet you.
Yeah, sure, sir.
Yeah, I come to Dr. Jiten's hospital for sometimes in case.
Okay, Jiten Kulkarni is my good friend. Yeah.
Yeah.
Sure, sir.
But remember about this planning of pregnancy. I think something has to be done for this.
Sure. I will
At
convey
least
this
in
message to
colleges,
our. Yeah.
some drives in colleges where there
Sir,
even some drive in the areas where the marriage registry occurs, court marriages occurs, where those are the areas where they should be provided with this concept of planning of pregnancy.
Yeah, we're having a public awareness committee, sir, in our AMOX Maharashtra level.
Yeah.
I will convey this message to that committee also,
Please.
to our
It
seniors
will
also.
be it will be the fantastic initiative, and it will reduce the at least we are coming to one cause. We are dealing with one cause at least. Rest genetics and other things is not in our hand.
Yes.
But at least one cause is in our hand. Is the healthy father and mother.
Yes, sir. Anything you need to add, Dr. Jaya?
Yeah, Ashwini, what is your father's name? You said he was a plastic
Dr. Avinash Yelikar, sir.
Oh
He
my
was also
God!
Ravin sir's
Oh my
student.
God! Sorry, Ashwini, we lost him. Yeah,
I know.
yeah. Okay.
I had seen him operating these cases
I know.
as a student and then
Yeah.
as MBBS student.
He's my Guru Bandhu. He's my Guru Bandhu.
Okay, I
He's my
know.
Guru Bandhu. Yeah.
He used to talk very high of Ravin Thatte, sir.
Yes.
I think Dr. Dias was also there during that.
Yes.
I think Sayan was one of the pioneers in all this
Yes.
plastic that time.
We used to have very huge cleft work.
Huge one, yeah.
We used to have a cleft clinic also with the dentist.
Yeah, and unfortunately, I saw all this in MBBS when I didn't get any hang of it.
Yes.
But then used to understand that something is happening about the lip and the palate.
Yes. Okay. Thank you very much.
Okay.
Thank you, Sujit sir. Thank you, Jaya madam. I really felt so nice to speak about this topic. I mean, otherwise nobody as a gynac would have ever invited me.
Your presentation was very good, Ashwini.
Yeah. She
It
was to
made
the point.
It prepared the talk for Nitin sir, actually, to know some of the basics.
Yeah.
So I'd like to give vote of thanks. I'm very much delighted to give vote of thanks in this occasion. I'm very much grateful to speakers today, Dr. Ashwini and Dr. Nitin sir, for enlightening us with their great knowledge. Many thanks to convener today, Dr. Jaya, who has worked very nicely today. Big thanks to Smile Train and Science Integra, who has given platform for this webinar. And no program is successful without participation of audience. So many thanks to all delegates who have logged in for this webinar. Thank you. Thanks a lot.
Thank you.
Thank you, sir.
Thank you.